so this patient, we're giving him, I mean, Vyxeos is an induction type therapy. It's not low intensity. It has similar intensity to 7+3, maybe lower early mortality, but count recovery is long. So is the goal going to be to take him, and Osama, maybe you want to address this, to take him to transplant? What are the things you're going to be looking for after, let's say, one induction, one consolidation, to consider transplant in this patient?
Sure. So this is basically, this case is a transplanter's dream. So what we have is a patient that has three main risk factors for very poor outcome without transplant, age being number one. So for 70 years old, less than 5% survive without transplant long term, poor cytogenetics, and antecedent MDS. So without transplant, this patient is doomed, even if achieves a CR1 or what have you. Meanwhile, good performance status, and other than the depression, no real bad comorbidities. So the goal is, in the hands of you, the leukemia docs, to put this patient in CR1 and take this patient to transplant as soon as possible. I must add that with the original cytogenetics and all the next generation sequencing, we send HLA typing on this patient. So by doing the day 21 or 28 marrow, we have a stem cell graft in today's age. We have plenty of stem cell grafts, whether it's umbilical cord in my institution, haplo, or others. So again, a transplanter's dream.
Well, I love your optimism, because it's glass half full. A lot of transplanters say this is a transplanter's nightmare because he has adverse cytogenetic TP53. So I hope all the transplanters are listening to your nice commentary that this is their dream. Okay, just one more question. Let's say hypothetically, of course, the other big elephant in the room here to think about is HMA-VEN. So this is a younger patient, where if this patient was 77, would this change your mind? Would age be the main thing you're looking at? Or would you say, no, even if he's 76, 77, I would consider Vyxeos if he's healthy? What do you think, Dr. Rizeri? Is age the big thing, or performance status, or others?
So I think that's a great question. And while age is important, I don't think these are necessarily the right cutoffs in terms of a biologic impact. Arthi Rao led a fairly large study published in JCO some years ago, looking at the Duke data combined with Hovan's collaboration, showing that cutoff between 45 years old and 55 and above year old patients, the biology being very different. So above that, I don't know if there's a real cutoff in biology there. If we're using age as a marker of fitness, I'm not a big fan of that. So I would rather look at other measures, whether it's Sears or other Charlson comorbidities strictly, because we certainly all have these 78-year-olds who are very fit in our eyes, who we certainly feel comfortable approaching with stem cell transplant. So having said that, have we transplanted successfully an 80-year-old patient? Sure. Is that our goal? No. There's so many other comorbidities that eventually catch up with those patients, probably not always related to transplant, that the delta of improvement there is really minimal. Yeah. So I think that's where you have a long conversation about the goals of care with such patients, and really try to delve into what the expected benefit's going to be. Yeah.
So I think, I agree with that it's not an absolute, it's a continuum, but as you get older, probably you're moving more and more away from intensive chemo, of course with exceptions.